Now, I'll give you a case done in this hospital only. And after that we've been thrombolizing. And the most fantastic thrombolysis which I did was about 10 days back. This is a gentleman who came with the left-sided stroke, and 1 hour he was here. We did an MRI, and you have to believe me, at 5 o'clock we started IV TPA. We finished the TPA at 6. At 7:30 in the evening I made a round. He had totally recovered. And as if the patient said, we are foolish of keeping him here because his neurological deficit had totally recovered. Now, this is a case which is one of our cases in the hospital, a very interesting case. You must hear it a little carefully. A 75 years old female, hypertensive, non-diabetic, no history of CAD, history of old stroke, left side evident 2 years ago. History of recurrent numbness, left side of body, lasting for half an hour to 1 hour for the last few days. She was getting recurrent TIAs lasting for half an hour, and obviously one would say, this is not a stroke, this is just because she has slept on the wrong side and whatever. When she came to us to the hospital, she had a blood sugar of 120, INA was pretty good, APTT was normal, ECG showed a sinus rhythm, and of course we did a CT scan which was normal. I still believe that the bottom line for investigations in an acute stroke is a CT. MRI is not the first investigation of the toilet till the time you are doubtful about your own diagnosis. She was admitted with the sudden onset of left facial and limb weakness at 8:30 p.m. on the night of admission. She was conscious, mild slurring, facial, 3/5 power, extensor plantar, everything fine. So she had a left stroke which was a right MCA. Another thing you must remember, which I'll come to, that if you have to treat a stroke, you have to do the NIHSS score. That's called the National Institute of Health Stroke Scale. If you do not know the NIHSS score, please don't come near a stroke patient. Don't thrombolize him. Don't do anything with him. I have conducted a couple of classes for you people also. A number of you must have attended, and I've got your certificate that you can do NIHSS scoring. NIHSS scoring is very simple, but it's not that easy also. This patient was thrombolized with the informed consent, and we gave her our TPA. You know the dose is 0.9 milligram per kilogram body weight. Don't forget that ever. 10% is bolus and 90% infusion over 1 hour. So if anybody asks you in the examination, there should be no doubt about the dose of TPA. We maintained the blood pressure. There were no complications. We did a CT head 12 hours later. Post TPA, there was a significant recovery by 48 hours, and the neurological status significantly improved after the TPA. Please remember, it's a very simple thing. Do not give any injections. Don't be heroic in the first 24 hours. Don't give unnecessary drugs. Don't give ecosprin. Just give statins. Don't put lines. Don't put catheters, except watch the patient carefully for any evidence of bleed. This was the pre-thrombolysis, which you can all see is the plumb normal CT scan. And if you see that for our own thing, we did MRI also. And you can see, except for this small little ischemic areas here, there's nothing much in this MRI. And then, of course, we did the MRI diffusion. And this is the post-thrombolysis. You can see I had done no damage to her. And she made a phenomenally good recovery. But let's go further. Now, what is, after all, TPA? Do you people know the concept of a penumbra? See, all these studies for the penumbra have been done in animals. There are no studies available in human beings except from what we are learning from the MRI. So if you include the internal carotid artery in the neck, you get two things. One is the inner core. In the inner core, the blood supply, the blood flow falls very fast. But this does not happen in the penumbra. So this is the central region of infarct, though that area you cannot salvage, that is gone because the blood supply has come down. I'm talking about the area which I can save. The central region dies a quick death. The theoretical outer, that's why I use the word, the theoretical outer penumbra of ischemic tissue, that is highly vulnerable but might be salvageable. So the bigger the salvageable area, the better results you would do. So our aim in neurology has to look for area which is salvageable, an area which I can reperfuse. Okay? The ischemic penumbra dies a slow death. You must remember that concept of apoptosis. Apoptosis means a programmed cell death. What I mean by that is, why till now we do not have a neuroprotective agent? Because the changes which are taking in the ischemic hypoxic cascade are very fast events. They're events like what? The NMDA receptor, sodium, potassium, calcium, and of course the free radical damage. Now each of these agents which are coming in the market, neutropil, etc., they may act on one part of the changes which are taking place. So we don't have a neuroprotective agent, and I don't know whether we will have it, because the ischemic penumbra is a very, very complicated area. So the ischemic penumbra, please remember, it's the word apoptosis. It is a programmed cell death. Now this is what it is. Of course, this is a very, very primitive representation. You have got the infarcted tissue, and this is the marginally perfused area which we can definitely reperfuse, right? Now the next. Now I would like to all of you, especially the those, to look at this beautiful slide. This is an old slide by Jones, which I love, is from Journal of Neurosurgery in 1981. What does it show? He's made an axis here and here, paralysis, time, infarction. So you can really appreciate that you don't have the time to waste. If you keep on wasting time, the paralysis keeps on increasing. So that is why time is brain. That's why even if you have 4.5 hours, don't wait for 4.5 hours. Do it as early as possible. How does it work? Does it work? I remember when this study which came, which all of you must read this study, which was this called the NINDS trial, which came in NEGM in 1995. It is not that we had not been using drugs. People tried urokinase, people tried ATPs, people tried all sorts of agents, streptokinase, but none of them worked. And all of them were very small trials, and all of them had high ranges of hemorrhages, so everybody gave it up. Till the time this landmark trial, which came, which all of you must read, it was called the NINDS trial. Now, it was very easy for the world and the neurologist to totally accept what NINDS came out with. And I must tell you, biggest people who were against the NINDS trial, I would say against, were the Britishers, because they are a group of people who are the conservative neurologists. They still believe in conservative neurology. Now, what was this NINDS trial, for your information? There were 624 patients enrolled, very high number. Mean age was late 60s. The NIHS Stroke Scale was 14, so pretty high NIHS stroke rate. See, you scale NIHS from 0 to 43. So, 14 is a pretty good scale. 45 were cardioembolic. 40 were large vessel atherosclerosis, and 15 were lacunes. So there was nothing which they left, and did not exclude patients who were already on aspirin. Now, this is the NIH Stroke Scale. It is a wonderful, standardized, fast and easy neurological examination. 13 areas are there: level of consciousness, vision, motor, ataxia, sensory, speech and neglect. But don't worry, if you start doing it it really doesn't take more than 5-7 minutes to finish the score. I don't know how many of you ever in the emergency gone and tried this. If you have not tried, at least now you should try doing this scale. 0 to 42 points, more the points, worse is the outcome. So there's no point saying there's a stroke, left hemiparesis or right hemiparesis, eyes are tonically deviated to the left, this and that. I want to know the score. Because if you tell me you have a patient who has an NIHSS of 20, he's going to obviously have a dense hemiplegia, the eyes will be tonically deviated to one side, he'll be drowsy. So maybe I will not thrombolize this patient at all. Now the inclusion criteria, extremely important. 1, ischemic stroke with clearly defined time of onset. Of course, if you are interested in knowing, now of course we are talking about wake-up strokes. So neurology is going forwards, and the way we are going with stroke forwards is really phenomenal. So we are talking about wake-up strokes. You don't know. So many times you say, the gentleman had a stroke. What time? I don't know. He said he slept and didn't get up in the morning. When he got up in the morning, he has a stroke. So you don't know. So now I have methods to assess approximately what time did the stroke occur. 2, measurable neurological deficit. This is exactly what I just stressed on you. 3, time between onset of neurological deficit and administration of TPA not longer than 3 hours according to NINDS. Exclusion criteria, very important. As I always say, if you cannot do good to a patient, please don't do harm to him. If you have any doubts about your diagnosis, don't thrombolize. If you think that he doesn't fit into exclusion, don't thrombolize. Don't do things which are going to harm the patient. We're talking about thrombolysis beyond the therapeutic period. I tell you, yes, you could, but don't take a risk where you cause an hemorrhage and he loses his life. Hemorrhage or hemorrhagic transformation, visible on CT or MRI, head trauma, major surgery, intracranial bleeding, systolic BP high, symptoms of SAH, GI bleed or hematuria, and of course arterial puncture, seizures at onset, raised partial thromboplastin time, international normalized ratio more than 1.4 platelet, and of course a very, very important factor is the serum glucose levels. If you have high serum glucose level, you cannot bring the sugar down, don't thrombolize the patient, you will kill him. Now, NINDS trial, what did it show? So now you know that I have a patient who's got this amount of neurodeficit, who's got inclusion exclusion criteria, fits into 4 thing. Okay, you have done it. What did the trial show? The trial showed that there was a major improvement in the NIHSS at 24 hours, TPA 47%, placebo 39%. In 24 hours. And I am telling you an improvement which I see in 2 hours. So, well, things can happen. Median NIHSS at 24 hours, TPA 8 versus placebo 10, significant when you did the post hoc tests. Symptomatic intracranial hemorrhage at 36 hours, TPA 6% and placebo 0.6%. This was the one which created the maximum havoc all over the world. That if you're going to cause 6% hemorrhage and the placebo is 0.6%, you're going to do a lot of harm to the patient. But what did we do for this? The neurologists didn't keep quiet. They said, let's pick up a group of patients who are at higher chances of having hemorrhage. Don't hemorrhage. Don't thrombolize them. But don't do thrombolize the one who deserve to be thrombolized. Death rate at 3 months, TPA 17% and placebo 21%. So this data is in front of you for you to see what TPA can do. Now again, for the benefit of postgraduates, there are certain scales which you must know. There is no choice. This is a very simple scale which is called modified Rankin score. So if you're going to do stroke work, you should know NIHSS, you should know modified Rankin. What's modified Rankin? Modified Rankin, again very simple, no symptoms, symptoms but no disability, slight disability but independent, moderate disability, moderately severe, bedridden. So this is what you would say. Now, why this scale becomes even more important? Because when you're going to convey to someone, what have you achieved? If your modified Rankin scale is 4 or 5. I give you a small example. All of you physicians and all the postgraduates must have seen people who have had a hemicorectomy for ischemic, large, MCA, malignant hemispheric infarcts. Oh, very good. The surgeon has done a very good job and come out. But the end of 3 months, what is the modified Rankin he has? He has 4 or he has 5. So what have you achieved? I would like this patient to have a modified Rankin of at least 2. So that is why you should be clear in what you are looking for. This is, of course, another very beautiful slide. Doesn't require much explanations. All of you must look at it very carefully, all the postgraduates. This is the placebo, this is TPA, this is the modified Rankin, and this is the percentage of patient. Look at the placebo and look at the TPA patient. All over, the TPA patients scored over the patients who were on the placebo element. Now, so this was the next trial which came, which was in the New England Journal of Medicine again, which was 2008. Where did they thrombolyze with etiplase 3 to 4 hours after the acute ischemic stroke? And what were the results they found here? The results again they found that even till 4 to 5 hours, the results were good. But that does not mean and does not give the authority for you to wait long, because the earlier you thrombolyze, better would be the result. So we went up to 4.5 hours. Now this is, of course, important to suggest. We should all should look at a slide. The early treatment remains essential. There's no point wasting time. You have to cut down your entry to the thrombolysis time to as much as possible, less as possible, because the results are going to be good. Now, the effect size in the 3 to 4 hours is confirmed by ECASS 3, and the confidence interval will significantly narrow in the new pooled analysis. However, the different effect size compared with early treatment remains. That's the gist of the problem and gist of what I've been trying to tell you. Now, of course, I'll keep quiet now. Dinesh will take over, but I just will wind up with this slide, that if you keep calm and love neurology, you'll become a great neurologist. If you are haphazard, hurry, karo, ye karo, you will achieve nothing. So we have the World Stroke Symposium. We have 2 international speakers. All of you are welcome to attend. I will not charge you a registration fee, but you must register yourself and make use of really what stroke is and what we are doing in this hospital as far as stroke is concerned. Greetings, I'm Dr. Renjen, a senior neurologist at the Apollo Hospital and a stroke neurologist. Welcome to the YouTube channel Stroke Neurology, wherein we'll take you through the basics and the recent advances in stroke. We would very much like you to subscribe for our channel right from the beginning to the end, where you would get the basics of stroke to the newer technologies of stroke, which are helping us all to treat a stroke patient in a better way.